Good evening, all the participants and doctors. So today the webinar is on the topic regarding the PCOS, that is recent trends and practical challenges in PCOS. And this will be conducted by our special guest speaker, Dr. Arudyuti Chaudhary. And we welcome you all to give your valuable time. And uh, let me introduce this page, Shield Connect, so you can also gather more videos or webinars from this site. Let me share the screen, 1 minute. So this is our page shieldconnect.in, where you can find various blogs and webinars and all the videos regarding the women health issues. And here you can see the blogs. You can find all the knowledge sharing blogs and articles written by the doctors. And this is the webinar uh, page where you can find the webinar where which topic will be conducted by which doctor on what time and date. So you can simply log in and get into the webinar. Then this is our key opinion leader page where you can find the contribution of many doctors are linked with the Shield Connect. Then we have a special awareness page in which you can find the immune booster page where we have reintroduced the Rudimin the new product, which will be very helpful for the respiratory immunity in this pandemic situation. Then there is the another page, PCOS awareness page, where you can find all the videos from various doctors from all the region in our India in all the languages, Hindi, English, Malayalam, and there is a one more special page regarding hypertension, Mother's Day, GDM special, and you can check it. So you can find all the videos regarding the special days. So this is our page, the Shield Connect. And now let me start with our webinar topic and our guest speaker. So let me have the brief intro. So today's seminar is on recent trends and practical challenges in PCOS, and it will be taken by our guest speaker, Dr. Arudyuti Chaudhary. So sir is done MBBS, MS and BGO through ICM and MCH, and sir is one of the best gynecologists at AK Paul Chaudhary, Binova Nagar, Guwahati. Sir is senior consultant gynecologist, laparoscopic surgeon, and infertility specialist in Guwahati. Sir is also well trained in advanced laparoscopy and infertility at Chennai and University Hospital of North Midlands, UK. Sir was also ex-associate professor in SRM Medical College in Chennai. So let me hand over this session of today's webinar to our sir, and I welcome you, sir, on our platform. So, sir, you can share your presentation, and I will hand over this session.
Good evening, one and all. Am I audible?
Yes, sir.
Yeah. Good evening. Once again, good evening. And we are going through a very tough time in this pandemic. I pray to the Almighty for the safety of all of you. So today's topic is that recent trends and practical challenges in PCOS. Everyone of us are familiar with this PCOS. There is nothing new to it, but it's just a recapitulation of what we have learned in our previous days or what we have learned in our day-to-day practice. So PCOS is a complex heterogeneous disorder. I'm not going to the classical definition of it. Every one of you know about it. It's a spectrum of manifestation that involves mainly the obesity, insulin resistance, hyperinsulinemia, and hyperandrogenism, oxidative stress, and there is a chronic low-grade inflammation. We will discuss in details about it. PCOS is not only now a reproductive endocrine disorder, but also a metabolic disorder with a future risks of type 2 diabetes, cardiovascular disorder, and in case of malignancy. So epidemiology, it is one of the most common endocrine disorder affecting the women of reproductive age group, seen in 8 to 15, 8 to 11% of reproductive age group women. Most common cause of an ovulatory infertility in women. Indians have amongst the highest prevalence rate in the world, 41% amongst the reproductive age group women. So it's a brief history of it. Originally described by Steen and Leventhal, 1835. Gradually, it was a reproductive disorder. Then there was a bilateral wedge resection of the enlarged ovary was therapeutic in normalizing the menses and fertility of the woman studied. Hence, the disorder was known as polycystic ovarian disease. With the progress of the knowledge, it was first reported that women with PCOS had hyperinsulinemia. Now, in the current status, it's a unique disorder of insulin, defect in the insulin, both in its secretion and other abnormalities. So etiopathogenesis of the PCOS, genetic, epigenetic, and lifestyle disorder, all of this together causes hormonal changes, which is led by obesity, and this also causes hyperandrogenism, insulin resistance. These two, hyperandrogenism and insulin resistance, together causes a low-grade inflammation in the gut, clinical with the clinical manifestation of hirsutism and acne in cases of hyperandrogenism. Both hyperandrogenism in the reproductive period causes oligoanovulation, menstrual irregularity, and subfertility. And with the insulin resistance, apart from the reproductive manifestations, we get certain metabolic manifestations as dyslipidemia, metabolic syndrome, type 2 diabetes, and there's an increase of cardiovascular risk. And all this combined together also gives certain psychological issues, which are body image, depression, self-esteem, and anxiety. Now, the metabolic syndrome, I'm not going in details of it. So the prevalence in PCOS is almost 43 to 46%. Type 2 diabetes mellitus or insulin resistance greater than or equal to 2, BMI more than 30, HDL less than 40 milligram, triglyceride greater than 150 milligram, BP 140 by 90 or more with medication, microalbuminuria greater than 20, albumin creatine ratio greater than 30 milligram. So these are the criteria for the metabolic syndrome in PCOS. Now, PCOS in adolescent manifest with menstrual irregularity, acne, hirsutism. There is a family history of PCOS, overweight or low birth weight, exposure to androgens during gestation, precocious puberty, obesity, insulin resistance. The diagnosis of PCOS during adolescence requires strict criteria, requires inequivocal hyperandrogenism, ovulatory dysfunction for 2 years or more than 2 years after menarche. The spectrum of PCOS from childhood to postmenopause. So the predisposing factors we get in pre-pubertal years where there is a genetic factors, that is in utero programming, increased AMH level during the puberty. There is premature adrenality, hyperandrogenism, increased GnRH pulse frequency, increased AMH level, ovarian volume, hyperinsulinemia. Same thing in non-PCOS. What we get because of these elevations of the androgenic hormone, we get acne, increased ovarian volume, irregular menstrual cycle, insulin resistance. So in reproductive years, it is irregular cycle, hyperandrogenism will continue, then subfertility or infertility, increase AMH, that is enter follicular count and ovarian, increase ovarian volume, glucose intolerance or insulin resistance. In postmenopausal years, the same group of patients where there will be increased prevalence of hypertension and dyslipidemia, which will give rise to high risks of cardiovascular diseases. The complications, we know that it's infertility, primary infertility was reported in 50% of the women, secondary reported in 25% of women, obstetrics 3 times higher risk of preeclampsia, 3 times higher risk of GDM, twofold increase in preterm deliveries, and twofold increase in risks of IUGR. Cardiovascular risk, twofold increase in risks of MI, and twofold increase risks of hypertension. Metabolic, that is the metabolic syndrome, 5 to 10-fold increase risks of developing type 2 diabetes and dyslipidemia. Oncologic increased risks of, due to the unopposed action of estrogen, there is an increased risk of endometrial cancer. And psychological, it affects the quality of life, self-esteem, and body shape. Long-term issues which are associated with PCOS, it gives to hormonal changes. Hormonal changes give rise to obesity, exacerbates the hormonal changes, increase of androgen, insulin resistance, which give rise to anovulation, which is again excess of estrogen. The insulin resistance give rise to uh, uh, type 2 diabetes, metabolic syndrome, and all of these give rises to hirsutism, acne, menstrual disturbances, subfertility, and cardiovascular risks in late age group. So obesity, and now we all know that we are going through the pandemic. Obesity is also a risk factor of COVID-19. I don't want to go in details about it. So what are the treatments available? What are the treatments available? One is insulin sensitizer, that is, we give metformin, which lowers the hyperinsulinemia, aids weight loss. The bad is that the insulin resistance is not seen with all patients with PCOS, and the worst is that there's the GI disturbances in many patients. Then next is the OCP pills, which might aid in regularizing the menstrual cycle, aids combating hyperandrogenism, but does not restore the bad thing in this regime is that it does not restore the ovulation. Okay. The worst of it that leads to weight gain, worsen insulin, increased cardiovascular risks, and increased risks of thromboembolism. Next, since it's an anovulation, so we give drugs, ovulation inducing drugs. It induces ovulation, but no effect on any other aspect of PCODs and not indicated in all PCOS patients. But there is an increased risk of cancer and OHS. Anti-androgens lowers hyperandrogenism, aid combating hirsutism. The bad thing of this regime is that it do not tackle the insulin resistance, do not restore the fertility, and it leads to hepatotoxicity. Whether we are treating the symptoms and not the cause. So the basic is the metabolic imbalance and the hormonal imbalance, which give rise to hyperandrogenism, LH-FSH imbalance, insulin resistance. A metabolic imbalance gives rise to insulin resistance, and excuse me, dyslipidemia. So all of these categorically manifest as oligo or amenorrhea, anovulation, acne, hirsutism, acanthosis nigra, impaired glucose tolerance tests, and obesity. So the current is that the same thing. It's the insulin sensitizer, then cyproterone acetate, that is anti-androgens, OCP, oral contraceptive pill for ovulation inducing letrozole, CC, comifen citrate, and for the cosmetic, we have the laser hair removal, bariatric surgery for obesity, and this cosmetic also for laser for acne therapy. The epidemiological link. So the PCOD increases the risks of type 2 diabetes more than 200%. Insulin resistance is present in 80% of PCOD cases, and 60% of the patient develops GDM, which later goes to type 2 diabetes. The It's an epidemic in India. So with the 41% prevalence rate, almost 117 million patients, and 1 in every 5 women are directly or indirectly affected with the disorder. Pathophysiology of PCOS, there's a considerable debate on it, but the key factor is that it is the insulin resistance and the low-grade inflammation in PCOS. The root cause of developing PCOS in women is due to the reduced or altered level of the myo-inositol in the ovary. We will go in detail in it. So the development of insulin resistance So insulin is primary. First, it controls the LH level. Second, the androgen. Women with PCOS have decreased sensitivity to circulating insulin irrespective of the weight, thus suggesting that the insulin insensitivity is intrinsic to PCOS. There is an inositol deficiency which drives the PCOD. The insulin resistance seems to be driven by the deficiency of inositol and D-chiroinositol. Insulin signaling is damaged in PCOD, so the inositol deficiency triggers this disruption of the insulin signaling. It leads to hormonal and metabolic defect by the disbalance of the LH-FSH pathway and the hyperandrogenism. Let's do pituitary dysfunction, increase in the frequency and amplitude of GnRH pulse, which results in elevation of LH. Excessive secretion of LH has traditionally been considered as a hallmark of classic PCOS. An altered LH-FSH ratio of more than 2, especially in obese women, is significant. Enhanced ovarian androgen production leads to abnormal LH influence on the thecal cells of the ovaries, which leads to again overproduction of androgens. All patients of PCOD do not have elevated levels of LH, but have elevated levels of androgen. This can be explained on the findings that ovarian thecal cells of women with PCOS have elevated CYP17 gene expression. Also, in summary, it is the environmental factors and the genetic factors which leads to inositol deficiency. This inositol deficiency deranged the insulin signaling pathway, which give rise to pituitary dysfunction enhanced ovarian androgen production, and development of the insulin resistance. So the clinical features, it's just a recapitulation. So first, irregular menses and infertility. In case of metabolic, we get the obesity, increased chances of type 2 diabetes, acanthosis nigrans, and androgenic is alopecia, acne, and hirsutism. Now, hyperinsulinemia, insulin levels may be increased in majority of the patient with PCOS. The hyperinsulinemic euglycemic clamp technique is the gold standard in assessing the insulin sensitivity, but it's not practical. The practical is that the ratio of the fasting glucose to the fasting insulin is a simple alternative effective technique. A ratio of less than 7 is highly suggestive of hyperinsulinemic state. And practical guidance is that a fasting serum insulin level more than 15 and serum insulin level after post 75 gram of glucose of more than 25 can also serve as a rough guide to the hyperinsulinemic status. It's the best way to come to a conclusion. So clinical features, oligo-ovulatory or anovulatory cycle results in continuous endometrial stimulation with estrogen causing endometrial hyperplasia, thus increased risks of endometrial cancer. Excessive facial hair is a normal racial trait for Indian subcontinent, acting via androgen receptors and secretory factors. Androgen increases the growth rate, diameter, and melanization of hair in androgen-sensitive areas. These thick, coarse, terminal hair in androgen-dependent areas point to an underlying hyperandrogenic state. Evaluation of the degree of hirsutism is done by adopting a modified Ferriman-Galway score, which evaluates 9 body areas on a scale of 1 to 4. The total scores are significant if more than 6 to 8. Acne in PCOD, it's a complaint of inflammatory acne. Even if responsive, lesions promptly recur on stoppage of treatment, development of multiple closed comedians, which transforms into tender. I don't want to go in details of it. Next comes the acanthosis nigrans and alopecia, typically thick, dark velvety skin situated on the nape of the neck, axilla, groins, and other frictional areas, often with the first clue of insulin resistance, and this is acanthosis nigrans. Not all cases of female pattern hair loss may be of androgenic origin. Patterned hair loss in PCOS may be difficult to distinguish from those secondary to other hyperandrogenic states. So management. So the first line of management is lifestyle modification. So improving lifestyle in obese patient, weight loss, changes in diet, physical activity is recommended. Weight loss decreases serum insulin, androgen level reduces the risk of glucose intolerance and type 2 diabetes mellitus. Pharmacological intervention in the presence of insulin resistance or glucose resistance or dyslipidemia that persists after lifestyle modification. Now, the aim of the treatment is to restore the normal spontaneous menstrual cycle, reduce the androgen level, overcome the insulin resistance, and improve the oocyte maturation and the quality of the oocyte. It's the same, the first line, overweight and obese patient weight loss with changes in the diet and physical activity, weight loss decreases. It's the same. Now, managing the menstrual disturbance. If the patient does not wish to conceive, medical therapy is directed towards interruption of the effect of unopposed estrogen on the endometrium. Non-fluctuating levels of unopposed estradiol in the absence of progesterone leads to irregular uterine bleeding, amenorrhea, infertility, and increased risks of endometrial cancer. Oral contraceptive pill elevates risks for cardiovascular disease. They cause dyslipidemia and increases the chances of thromboembolic events. There are evidences suggesting increased risks of type 2 diabetes mellitus with OCP usage. A low-dose oral contraceptive pill is therefore recommended, and usually the fourth generation one. Treating the anovulatory infertility medically, ovulation induction. The recommended first-line treatment for ovulation induction remains the anti-estrogen clomiphene citrate. Recommended second-line intervention is the exogenous gonadotropin letrozole. Then comes the retrozole. Strong evidences confirm efficacy of inositols in restoring the fertility in PCOD patients. Surgical, that's the ovarian drilling. Still, there are controversy on it. So the current treatment paradigms, that is metformin, pros of it attacks the insulin resistance. It has widely used. Cons, does not prevent gestational diabetes mellitus, cannot manage severe cases, not tolerated by all. GI disturbances are there. Process placental barrier, fetal risk is unknown. Category B, drug. Then insulin, efficacious, injectable, hypoglycemia, cons, hypoglycemia, weight gain, unable to prevent fetal complications of gestational diabetes mellitus, does not tackle the root cause. And the recent, we get the inositol. Pros, both prevents and manages the gestational diabetes mellitus, attacks the root cause of gestational diabetes mellitus, leads to a favorable fetal and maternal environment, shown to be superior to metformin, safer than both insulin and metformin. But still, certain controversies are there. There was a repetition of it. So we are in a need of a better treatment. So the basic is the insulin signaling pathway. So it's just a recapitulation. The insulin receptor, which is restricted to the cell membrane, when the subunit is phosphorylated, insulin receptor substrates are activated. So these molecules, P13K, talks to the insulin receptor substrate, which then leads to the phosphorylation phosphatidyl inositol. This myoinositol increases insulin sensitivity by making more phosphatidyl inositol available. More biochemistry. Myoinositol and D-chiro-inositol deficiency in PCOS. We all know that both myoinositol and D-chiro-inositol levels are very low in PCOS patients compared to normal subjects. So myoinositol and D-chiro-inositol in PCOD in the ratio of phosphates to 1 normalizes the insulin signaling and the glucose metabolism, which does not eliminate but diminishes the insulin resistance. This combination also decreases the inflammation in the ovarian thickle cells. As a result, the androgen levels comes down and the fertility is restored. Both the, as the insulin levels normalizes, weight loss starts. As LH levels comes down to a physiological level, menses starts regularly. The role of myoinositol and D-chiro-inositol in PCOS in Indian patients. The effect of myoinositol and D-chiro-inositol in Indian PCOS patients is a paper which was presented at ISAR 2020. Non-randomized pilot study. Study was a 3-month observational study, which was an open level. All subjects who have signed consents from and are prescribed with minoxidil 2 gram and D-chiro-inositol in a micronized powder formulation twice daily. Data was recorded once at baseline and at the end of 3 months. A standardized CRF was used to record observation. A study was done in initial set of 50 patients. Clinical pregnancy rate were also observed. The result, out of 50, 46 patients completed with the study for 3 months. There was a statistical significant improvement levels in the FSH levels and LH-FSH ratio. Regularization of menstrual cycle in patient. 20% of the patient conceived after treatment with minoxidil and decarbeniazole. To conclude, this was the first Indian study to observe the effects of the minoxidil and decarbeniazole in an Indian population of hormonal parameters and clinical pregnancy rate. Minoxidil 2 gram twice daily, good improvement in hormonal parameters. Minoxidil 2 gram and decarbeniazole improves the clinical pregnancy rate in PCOS after 3 months treatment. There is a need for further well-randomized trials in the future. So for meta-analysis, 9 randomized control study involving 240 cases. Along the 240 control, there is a significant decrease in the fasting insulin level, significant decrease in homeostasis of the HOMA index, a, a trend of reduction of testosterone, significant increase in the there is a beneficial effect of minoxidil in improving the metabolic profile of PCOS women concomitantly reducing the hyperandrogenism. So what does the international consensus say? This was published a result from International Consensus Conference on Minoxidil and Decarbeniazole in Obstetrics and Gynecology, the link between the metabolic syndrome and the PCOS. So the conclusion is clinical data demonstrate efficacy of minoxidil and decarbeniazole in treatment of PCOS. The evidence are strongest for dose of 4 gram per day of myo-inositol. So the role of myoinositol in gut dysbiosis. Now, the new theory, which is that is the dogma theory, dysbiosis of gut microbiota. So, the diet rich in saturated fatty acids and sugar leads to growth of bad gram-negative bacteria in the gut, which reduces the bifidobacterium and lactobacillus, which results in cell wall of gram-negative bacteria immunostimulant lipopolysaccharide. This lipopolysaccharide enters the systemic circulation. Innate immune system is activated, which as a result, cytokines are released. These cytokines causes a low-grade inflammation in PCOS. So the difference between a healthy gut and a leaky gut, the healthy gut, normal intestine permeability, intact intestinal barrier. We all know these are the columnar epithelial ciliated cells. This is the mucosal layer and this is the intestinal content. So this barrier is intact. But in case of obese or in PCOS patient, it has been seen that there is a leaky gut, increased intestinal permeability and damaged intestinal barrier. Due to the damaged intestinal barrier, undesired passage of pathogens, gluten, caseins, etc. passes through these cells, and then this causes a low-grade inflammation. And the homeostasis is not maintained between the gut microorganism, food particles, toxins. So the inflammatory markers in PCOS are raised, and this rise to gut permeability, metabolic endotoxemia, which rises in the CRP level, tumor necrosis factor IL-6. Now, the role of this pro-inflammatory cytokines. The tumor necrosis factor alpha causes phosphorylation of the insulin receptor protein, leading to insulin resistance. So in lean PCOS, this leaky gut causes increase in the cytokine IL-6 and TNF alpha. Both TNF alpha and IL-6 have been linked to insulin resistance. Endotoxin lipopolysaccharide in the systemic circulation leads to increased fasting glucose, increased insulin levels, and insulin resistance. Human studies have provided that good gut microbiota improves insulin sensitivity. So the dogma, dysbiosis of gut microbiota, to summarize, increase in gut mucosal permeability leads to lipopolysaccharide from gram-negative bacteria, enters in the systemic circulation, activates the innate immune system, induces chronic low-grade inflammation. This low-grade inflammation releases cytokines. This cytokines interferes with the insulin receptor function in their receptors, and this leads to increase in insulin resistance, and the increase in insulin resistance leads to increase in ovarian androgen production. So obesity and gut permeability, increased adipose tissue increases gut permeability. Visceral fat deposit increases the cytokines, that is the tumor necrosis factor alpha. Increased cytokines leads to reduction in anti-inflammatory protein adiponectin. So in conclusion, there is a chronic low-grade inflammation in PCOS. So to summarize, which leads to the chronic low-grade inflammation, first, lifestyle, that is diet, increase in animal protein, trans fatty acids, hyperglycemic index, diet which have a high glycemic index leads to chronic inflammation. This chronic inflammation leads to reactive oxygen species, abnormal mitochondria. As a result, there's a poor oocyte quality. This chronic inflammation also impairs the ovulation. Now, due to the diet and lack of exercise, lack of physical activity, leads to obesity. Obesity, in turn, leads to increase of adiposity, leptin, and free fatty acid. These adipocyte, leptin, and free fatty acid increases the cytokines, that is the tumor necrosis factor, causes dyslipidemia, increase of CRP, which leads to insulin resistance, and again, it is the PCOS. This PCOS leads to again increase of androgen. So it's a vicious cycle between the lifestyle, obesity, PCOS, and chronic inflammation. How to management of gut dysbiosis. So now the PCOS management is not only restricted to the reproductive age group, but it has to be managed over the lifespan. Alpha lactalbumin. What is its mode of action? So this alpha lactalbumin enhances this barrier. So this alpha lactalbumin enhances the barrier, inhibits pathogen adhesion to the cells, com competitive exclusion of pathogenic microorganism, production of antimicroorganism substances. It modulates the immune system. So, thus it increases the adhesion to the intestinal mucosa. As a result, it prevents this leaky gut. So, in conclusion, the alpha lactalbumin rebalances the gut dysbiosis and achieves the eubiosis. So PCOS is a state of myoinositol deficiency. What we get in a normal oocyte, we get the ovarian follicle, the capillary vessels, theca cells, follicular fluid. Normal follicular fluid is rich in myoinositol with a ratio of 100:1 with dicaroinositol. But in case of PCOS, there is 500-fold reduction in myoinositol. As a result, the oocyte quality is disturbed. So the myoinositol and dicaroinositol ratio is 0.2:1. So PCOS with gut dysbiosis, that is myoinositol and alpha-lact. What does the clinical evidence show? So the effects of myoinositol plus alpha-lactalbumin in myoinositol resistant PCOS women. I'm coming to the conclusion of it. The study, 37 anovulatory women were taken, myoinositol, 23 ovulated, 14 no ovulation. These 14, those they didn't have their regular periods, they were given again myoinositol and alpha-lactalbumin. 12 ovulated, so there was a total 95%. There is also a reduction in the hyperandrogenemia. So it's the level of evidence, clinical evidence of myoinositol in PCOS. Lots of studies are there, but myoinositol and metformin both reduce the HOMA insulin resistance, and there was no statistical significance between the two. So there is a comparative study between the myoinositol and metformin in the treatment of insulin resistance. The conclusion is myoinositol and metformin both reduce the HOMA IR, and there was no statistical difference between the groups. Myoinositol administered positively affects the hyperinsulinemia and hormonal parameters in overweight patients with polycystic ovary syndrome. Effects of myoinositol and dicaroinositol on hyperandrogenism and ovulation in women with polycystic ovary syndrome, a systemic review. Conclusion: myoinositol and dicaroinositol appear to be effective in improving the ovulation and reducing the hyperandrogenism in women with PCOS. So the pillars of this treatment is 40:1 ratio. International consensus. But the take-home message: if obese, weight loss should be recommended prior to initiation of therapy. This is the basic. If obese, weight loss should be recommended prior to initiation of therapy. Hyperandrogenism, hyperinsulinemia should be looked for in every PCOS woman. Ovulating inducing agents and adjuvants should be customized. PCOS patient is the most difficult to treat with IVF because of the risks of failure and OHS. Cycle cancellation rates and risks of OHS are higher. Fine tailoring of ovarian stimulation is necessary to avoid complications. Treating physicians should be aware of the difficulties and the remedies. The comprehensive management of PCOS requires a patient-centric, multidimensional approach, significant time dedicated to thorough education and counseling, remaining up to date on newest advances in the literature. Improvement in health of the PCOS woman in pregnancy could prevent disease in the next generation. So to conclude, the PCOS, P for prepare, We should prepare and assist women with the necessary information and resources needed to get tested, communicate communicate information to the public and to the women diagnosed with PCOS, overcome, assist women diagnosed with PCOS to overcome their symptom and lessen related risks, and provide a support network to freely and openly discuss all aspects of PCOS. Thank you all.
Thank you, sir. Thank you for providing this important information on PCOS. So, I would like to ask a few questions which we received from participants. So, the first question is if the woman is having PCOS,
Hmm.
do she still need to use birth control pills?
No, see, PCOS, you can use a birth control pill. That was a, but we have to see the pros and the cons of it and what combination of OCP we are giving. Okay, because this has an again in the long run, it should not increase the it should not lead to weight gain, and the other factors are also to be. It should not cause dyslipidemia. It should not cause the weight gain. It should not cause hepatotoxicity. So the other factors are to be taken into account.
Okay, sir. And the second question is there any effect of thyroid disorder on patient with PCOS? And is it more prevalent in hyperthyroidism or hypothyroidism?
It is more prevalent in hypothyroidism, but thing is that since it is an endocrine disorder, when there is an obesity, dyslipidemia, thyroid will come. It is not no longer a disorder. It comes under the metabolic syndrome.
And one more question is that if a teenage girl is having a normal acne, overweight, and having some irregular menstrual cycle, so should they think that it is a normal and not PCOS? Or should this teenage girl needs to consult doctor for detecting or checking the PCOS?
No, here this say the earlier we start, it is
Mhm.
better.
Mhm.
A thorough history and counseling is required. So the basic is that it's not only treating. Previously, it was a reproductive age disorder. Now we have to treat throughout the lifespan, and we have to prevent the next generation of getting it. So a thorough history, both antenatal history should also be taken, whether there was an exposure of androgen or what of the
Mhm.
mother, and then a thorough history has to be taken. The family history is also to be taken. If there are some predisposing factor, that is family history, there is the diabetes, and there is an excess of mother has also PCOS, or some sisters have also, because there is a genetic and epigenetic
Mhm.
factor, which
Mhm.
and it, it's not only a lifestyle disorder, but genetic factors also plays a role on it. So it's better to at the teenage level to do a proper counseling and explain to it and do a proper treatment in avoid the complications in future.
Thank you so much for providing your valuable information on these questions and as well as on this topic on our webinar, the Shield Connect. And I thanks all the participants to listen this webinar by our guest speaker. And I also thank our colleagues from Shield who made this possible for this conducting this session. So thank you, sir. And we will like to have more such webinars with you in future on Shield Connect. Thank you so much.
Thank you.
Bye, everyone.
Thank you,